Hi, I want to thank you for joining me. My name is Cami Hurst. You're joining me here in my office in Meridian, Idaho. I am a PhD in clinical sexology. I'm a licensed marriage and family therapist, and I'm a certified sex therapist. I really enjoy working with individuals and couples in my private practice here doing therapy, and I really love doing sexual health education, which is what we're going to do today. So excited. So today we're going to be talking about male sexual health. Specifically, we're going to be addressing PE and ED concerns and things that you or your spouse can do or do together. So who am I? Here are my credentials so you can know how much you should pay attention to me or disregard. But these are my credentials. I've been spending the last 15 years becoming an expert in sexual health and sex therapy and relationship and sexuality therapy. I do have a podcast called Sex Therapy 101, where I address a lot of sex education and sex therapy questions for listeners at home, some education. And I'm also the president of the Idaho Association of Sexual Health Professionals, which is a board that I really love serving on currently. So where are we headed today? Today, we're going to talk about, first, we've got to define what is sexual health anyway. Then we're going to talk about how do most men's bodies function. And then we'll talk about some common male concerns and what to do about them, specifically PE or premature ejaculation and ED or erectile dysfunction. So let's talk for a minute about the impact of sexual concerns. Sexual functioning is a major part and an expected part of relationship over the lifetime in a married or romantic relationship. We've got some research that suggests when sex is functional and healthy, it plays a positive role. It plays about a 20% contribution to the overall satisfaction of the relationship, saying it's one of many parts that make the relationship enjoyable. However, it plays an inordinate role when things are not going well. It robs the relationship of about 80% of its enjoyment and its satisfaction when sex is a source of distress, it's a source of conflict, and it's a source of insecurity in the relationship. Treating sexual issues by hoping they get better over time is not a great solution. So we understand that if a sexual problem persists for longer than 6 months, does not resolve on its own, you likely will need sex therapy for it to resolve. You'll need specific attention. Most sexual difficulties don't go away on their own. And we treat sexual problems directly. So there was a traditional strategy in the 80s and 90s where if we just treated the relationship, if people had a happy relationship, then sexual functioning would take care of itself. And we understand that that is not true. You can have a really satisfying relationship and still have some difficult aspects sexually, and that those need to be directly addressed head on rather than hoping they'll resolve themselves by addressing emotional connection or communication, things like that. So how do we define sexual health? Here's how I define sexual health. I'd like to think of this as a pyramid with a foundation that we lay both developmentally and by order of importance. That we've got some research that suggests there's some principles of sexual health that we need as a foundation to make sure that we don't hurt each other with sex. And after that, we need some really great education about medically accurate expectations. And then we need to incorporate and be an expert about what are our personal tastes and preferences. And then on top of that, we incorporate our chosen values. They may be from our childhood faith. They may be values that we've philosophically adopted or politically adopted, but those are the crown rather than the foundation. What many of us as adults are experiencing was having been raised perhaps in an abstinence-only environment, and we didn't have the foundation of these 6 principles of sexual health. We didn't get medically accurate expectations. We weren't encouraged to explore our personal tastes and preferences. We are uncomfortable with other people's personal tastes and preferences, but those values overshadowed the other things that we also need to have sexual health in our relationship. So we're going to start with the 6 principles of sexual health. They are consent, non-exploitation, mutual pleasure, honesty, shared values, and protection. And these aren't coming from me or a theory out there. This was research done by the World Health Organization when they looked at this from a community health standpoint of what would we need in place to prevent sexual harm from being incurred in our families, in our communities. And they realized that these were the 6 things needed to make sure that sex was not harmful to ourselves or to those around us. And we're going to run through them. Another place where if you'd like more information on the 6 principles of sexual health is you can research it through the World Health Organization or through the Harvey Institute, but there's also lots of articles and podcasts if you'd like to spend more time on this. The first is consent. Consent means voluntary cooperation. It means that both parties are there willingly and happily. No means no has evolved to yes means yes, which has evolved to are you enthusiastic about our encounter? And consent can be withdrawn at any time throughout any experience. And you want to establish consent through each step of the interaction. If someone says yes to sex, I'm not quite sure what they're saying yes to. What does that mean? What's going to come, afterwards? So it's important to have these kinds of conversations and ask yourself, how are we practicing consent in our relationship? It's a major question to start with. The second principle that needs to be established is non-exploitation. Exploitation is simply when one person leverages power to get what they want from someone else. This can happen in really nefarious and even criminal ways, but this can also happen in maybe innocent, more benign ways. We want to be aware of it, though. We want to make sure that we aren't using leverage or power in order to gain access to sex with our partner. Some forms of power might be financial negotiations or establishing who has more authority in the relationship, or anything where we're using power to leverage someone else to get them to go from a no to a yes is unhealthy and will damage the relationship and the individuals. Mutual pleasure is the third principle. Pleasure should always be the focus, and it should be mutual. It should be enjoyable for both parties. There should be access and equal opportunity to have pleasure. And pleasure is not synonymous with orgasm. Okay, I want you to understand that people can have an orgasm and maybe not have had a great time, and people can have a really good time and maybe not have had an orgasm. Pleasure is unique from person to person. How we experience pleasure, what kind of touch is enjoyable, what kinds of thoughts are enjoyable, what kind of context is enjoyable. This is all very personal. Pleasure is far from one size fits all. And getting a self-report from your partner is the best way to assess if the encounter was pleasurable or not. Rather than trying to read their cues or look for an erection or an orgasm, the best report is, did you have a good time? Is there anything that would have made it more enjoyable? Honesty is also a sexual value. It's a foundation. Honesty with ourselves, honesty with our partner, honesty about what the experience is. Without honesty, sexual relationships will not be able to have effective communication, and they won't be able to uphold any of these sexual principles at play. The next is shared values. And I care a little bit less about if you share the same values up front. I care a little bit more about how you negotiate this. And if you're aware of your core values, and if you're aware of your partner's core values, and if you make room for the differences where there may be a core value for one and not another, and do you approach that with acceptance or do you approach that with judgment? And all people deserve access to protection from unwanted pregnancy and protection from STIs or infections. And this requires honesty with our partner about how we're practicing that. It requires consent for agreements about how we're practicing that. So that's the foundation I want you to keep in mind when we talk about sexual health. How am I defining sexual health? Think about this. I'm putting the foundation here, these 6 principles of sexual health. And then we're going to talk about medically accurate expectations of a male body. How do most male bodies function? Well, all sexual bodies function biologically, psychologically, and sociologically, meaning there are biological factors that impact our function, there are psychological factors that impact our function, and there are sociological factors that impact our function. And so if you are in a discussion or you're looking for resources and it really says, this is it, this is the one way to do this, I want you to kind of put a question mark because there can be all sorts of causes and all sorts of suggestions that are helpful. And we're going to look at what are the biological causes of both PE and ED, what are the psychological causes of PE and ED, and what are the sociological causes of PE and ED. Now we're going to talk a little bit about how most bodies function, and we're also going to talk about how they vary as well. So there is variability when it comes to the male sexual organs. And it's important to know that size is completely hereditary. Almost. It's highly, highly hereditary. It's also important to realize that there are showers versus growers. Some men are insecure about size, and a penis can function a lot of different ways. Some men's penis withdraws internally and it looks much longer when erect, and some men's penis just goes flaccid and does not pull back internally, and it looks much longer when it's erect. But these are just very, very common variabilities in the penile organ. It is good to know that women report that girth may be more important than length. Length has very little to do with female pleasure. The vaginal canal doesn't have a lot of nerve endings. The minority of women have an orgasm through penetration alone. And so the penis matters quite less in sexual satisfaction for women than men may understand. And some people would say that weight loss changes the length, but not really. It just changes the amount that you can see or that you visually have access to. And here you can see it's also varies by geography as far as our racial backgrounds are concerned. That these red areas, the average length is about 3.8 inches. In the orange areas, the average length when erect is 4.7. Yellow is 5.6, and green, much rarer, is 6 inches or greater. There is some consistency though. So people with penises may have up to 3 to 5 erections per night. And there are different kinds of erection. This nighttime erection you can think of as a cleaning facility coming in and maintaining the organ. These erections are not necessarily because you are aroused or because you are horny or had an erotic dream. These are erections where this tissue needs to stay elastic and it needs to have access to oxygen. And our tissues, when they are elastic, if they are not exercised, then they become brittle and painful. And so these are really just your body doing maintenance. Penises can break, but not in the way that you think. They are not a muscle or a bone. However, when erect, and you can look over here at this anatomy, when those two cavernosas are full of blood, it's just spongy tissue that becomes very rigid, and the organ can break, which means one of those cavernosas could burst, and it could cause damage to the exterior skin and could need some reconstruction. The average length globally of an erect penis is about 5 inches. It's important to understand that ED can affect young people. It can be a signal of serious health problems. It's important to know that an erection is not required for a male orgasm. It's only required for penetration, and penetration is not necessary for an orgasm. Your lifestyle choices can make you more prone to ED than other individuals. And ED stress, the stress about ED can make it worse. Not all erections indicate arousal, and a lack of an erection does not indicate a lack of arousal. One can be very aroused and still not experience an erection. Now, there are some similarities also here anatomically between men and women. If you look here at the right, this is so fascinating to me. You can see this is the internal anatomy of a embryo at about 9 weeks, and we've got something that is a head, something that is folds, something that is an opening, and an anus. And about 11 to 17 weeks, there's a hormone wash in utero that the hormone wash will then create male genitalia. Without that hormone wash, it would continue to develop as a female. But these parts are the same parts, organized differently. This bulb here will become the head of the penis, and this bulb here will become the clitoris, okay? And so when these folds close, this becomes the penile shaft. But when these remain open, these are the labia minora and majora. And so you can think about these as being homologous, or the same structures organized differently, but they have very similar sensation. And so if you're wanting to create a similar sensation to what the head of the penis experiences, that does not happen inside the vaginal canal. That happens at the same anatomical part, which is the clitoral head. And so the clitoral hood is analogous to the male foreskin. And the labia minora close, which become the scrotum and the sac. It's just fascinating to understand how we vary, how we're similar, and how we're just organized differently. Now let's talk for a minute about the phases of sexual response that is experienced typically. Let's go back. So there are stages, right, that we want to focus on and understand correctly. The first stage would be the excitement phase, which would be arousal, which is when the blood fills up those corpus cavernosa and you get either a partial erection or a full erection, depending on both the mental arousal and the physical arousal happening. You need both at play. And it's important to understand that this is non-oxygenated blood. So once the blood enters an erection, it's cut off. So sometimes there is a very normal lack or loss of arousal, even when you're very mentally stimulated, because that blood needs to be oxygenated. If you think about putting a rubber band around the bottom of your finger, it kind of starts to throb, and it needs oxygen to keep that organ healthy. And so you may lose temporarily the erection and then get it back because simply that organ needed blood. And then the plateau phase is when this color deepens often, the prostate gland enlarges, the scrotum thickens, the pelvic floor becomes more tight, and you secrete what many people call pre-cum or pre-ejaculate. That can contain sperm. So if you're trying to prevent pregnancy, you're going to want to avoid that. But also it plays a biological function where it sterilizes the urinary tract. So because urine may have traveled through there and left some bacteria, and so this pre-cum or this pre-ejaculate sterilizes before the ejaculate comes through, because it could contaminate your female partner. And then here's the orgasmic phase, which starts in the prostate. The prostate begins contractions, and the seminal fluid and the sperm combined, and course of pelvic floor contractions expel the ejaculate out. And then the resolution phase is when all of that congestion, the blood returns back to the body and the erection recovers. And this is the resolution phase. And many men, most men experience a refractory period where they need some time, and it grows, it gets longer as you get older, some time to recover before you're able to have another erection or ejaculation. Now, let's do some facts about male-bodied orgasm. Let's make this a little smaller. So refractory periods vary among men. Young men typically recover faster than older men, and there's a wide variations in how long sexual stimulation can last before the ejaculation occurs. Pre-ejaculate does contain some sperm. It can impregnate women even without penetration. And anally massaging the prostate is reported to be a source of some of men's most pleasurable orgasms because of that biological factor of orgasm starting in the prostate and being able to massage that directly. This can also be an answer for individuals who have permanent erectile dysfunction and are looking for ways to orgasm without an erection and without penetration. Now, orgasm and ejaculation are not the same biological function. They happen at the same time often, but they are not the same function. An orgasm typically lasts between about 17 seconds. It can vary, perhaps up to a minute. Typically consists of about 10 to 15 pelvic floor contractions. And an orgasm is a neurological event that travels up the spinal cord and creates pleasure and pulsation for the individual. Men who have permanent ED can still have an orgasm as long as that spinal cord does not have any injuries or lesions like MS or accidents. As long as the spinal cord is intact, we can have an orgasm for a male and female. But ejaculation is often a secondary product of those convulsions, of those contractions. And, larger amount of volume or ejaculate can be seen with greater durations of abstinence. So sometimes if you're experiencing some infertility, that's why you space those out. Men who've had their prostate removed, though, will have a dry orgasm, meaning there's no semen and there's no sperm and there's no prostate to create those early contractions. So it can feel very different, but still very possible. Men who've had a vasectomy will still ejaculate. It just will not have any semen or sperm. Frequent ejaculations actually are highly correlated with lower prostate cancers. So there is health benefits to frequent ejaculation. Let's talk for a minute about the most common concerns that men have about their sexual functioning. First, we'll talk about premature ejaculation, and then we'll talk about erectile dysfunction and what you can do about them. So premature ejaculation is the most common and prevalent sexual disorder among men, especially among younger men. It affects about 30% to 50% of the male population. How are we diagnosing this? I've had a lot of clients come in and believe that they have ED or believe that they have premature ejaculation when they are functioning quite typically and healthily. So here's what we're looking for to determine if this is a concern or not for you. The first criteria is consistently ejaculating within 1 minute or less of vaginal penetration or active stimulation, whether it is a hand or a toy or a mouth or a vaginal canal. Ejaculating less than 1 minute of penetration would be the definition. An average length of stimulation, either through penetration or other active stimulation with a hand or a toy or a mouth, is about 5 to 7 minutes of active stimulation before an ejaculation. That is the most common, that's our healthy range. Now, this needs to have gone on for at least 6 months, because it's very possible to have a few times where you premature ejaculate. prematurely ejaculate. And it needs to be the experience of about 75 to 100% of the time. So this being infrequent with less than 25% of the time and only occasionally does not, you wouldn't qualify for this diagnosis. It also needs to create some distress for you, perhaps for your partner. This is only a problem if it's a problem. I know plenty of couples who have very satisfying sex lives, and the male comes very quickly, but they've created a strategy where they're both very satisfied. And so it's only a problem if it's a problem. It doesn't need to be a problem. And we need to know that this is not happening because of a mental disorder, some medication, a substance use, a medical condition. There are lots of medications and conditions that can create symptoms like this that would mean that it's a side effect, not a diagnosis. And then we look at, how long and how severe. Is this something you've experienced your whole life? Is this something that's crept up gradually? Does it happen in all situations or not? One question I'll often ask my clients is, does this happen when you're alone or only with a partner? And that can be a good indication of if it's generalized or if it's situational. We're going to take a little bit of a different approach depending. Now, there are biological factors for this. There can be neurological concerns that create hypersensitive reflexes. There can be physical illnesses. This is associated with UTIs and prostate infections. There can be physical injury, which may create temporary or permanent premature ejaculation. And this is often a side effect from opiates or over-the-counter drugs like Sudafed even. Some biological treatments. I'm going to refer you to a urologist first to see biologically what they see and if that's all we need to do to treat it. You might do some hormonal testing. I'm going to refer you to a pelvic floor physical therapist. Men have just as much of a pelvic floor as women, and they have just as many needs for pelvic floor physical therapy as females. It's not just for those who've birthed babies. And I'm going to give you some suggestions for some premature ejaculation specific exercises that you can do at home, alone, or with your partner. Now, what are the psychological impacts? What psychologically can be happening, even if nothing biologically is happening? An ejaculation and orgasm is very much a nervous system event. And so we're going to look at anything impacting your nervous system, which would be depression. It could look at some anxiety, also psychological distress, like a loss of confidence, frustration, body issues, occupational stress, financial stress. Stress impacts your nervous system, which is going to impact your sexual functioning. And then we'll look at if there's any psychosexual skill deficit, if there's a lack of understanding about how the body responds, or if you've got unrealistic expectations about what should happen, or if there's a preoccupation about the PE that is creating a cyclical event, that the anxiety about the PE causes the PE, and then you have some PE, and it's this never-ending cycle, all rooted in anxiety. What are the psychological treatments going to be? We're going to look at CBE, which is addressing the cognitive, behavioral, and emotional impact. We're going to address the behaviors, offering some freedom to choose behaviors that are responsible, accountable, mature, ethical. We'll foster a non-judgmental environment to see if there's any behavioral interventions we can do. We'll increase mindfulness and your somatic intelligence. We'll address the emotions you experience. Emotions are energy. They're not good or bad. We'll look at any cognitions, if there's some assumptions, some unrealistic perceptions, explanations, expectations, those kinds of things. And here's some of what I'm talking about as cognitions. There are some detrimental cognitions when you're experiencing this. One is the idea that good sex means long intercourse, or that sex should always be romantic, or that sex should be easy, or that ejaculating quickly means something negative about you, like you're selfish. More beneficial cognitions would be that good sex involves being flexible and sharing pleasure and connection. That sex is sometimes romantic, sometimes routine, sometimes meaningful, sometimes mundane. A more beneficial look is that sex requires lifelong adaptation and adjustment, which it does. And the fourth is that generous lovers offer equal pleasure opportunity, independent of the timing of an orgasm. It's very interesting that for women who come quickly, we don't assign it as a dysfunction. We just think they were really turned on. But for a man who comes too quickly, it's a problem. You know, we've got these beliefs in our culture about timing. PE can also be from a social factor. It can be an indicator of relationship distress. It can be an indicator of a hypersensitivity or a fear of disappointing your partner, self-blame, being over-apologetic. It can often create a situation in which you are self-absorbed in the sexual encounter and you're defensive about if it matters to your partner or not, or maybe dismissive of their needs, too focused on your own. And if there's a high conflict, high criticism, high blame relationship, that's going to impact your sexual functioning as well. Sometimes religious beliefs or your family of origins attitudes about sex can be a cause here as well. So what are some social treatments when that's the cause? We're going to look at any unrealistic expectations that you have of sex and create some more realistic ones. We're going to address any religious ideas or ideas from your family of origin that were not helpful or are not correct. And we'll look at addressing the relationship quality. Here's some specific suggestions for PE. Some yeses. Exercise in ways that make you comfortable with your body, make you comfortable with your whole body, make you comfortable with your nudity and your genitals, and that it becomes, you know, very accepting of your whole self and the different ways that you may function. We'll look at embracing pleasure rather than focusing on performance. We'll try to reduce anxiety through practicing non-judgment and physical relaxation and mindfulness. Physical relaxation is a huge part here because often premature ejaculation means that your pelvic floor is too tonic, it's too tight. So we don't want to be doing Kegels really here. We're actually wanting to practice in pelvic floor physical therapy, relaxing your PC muscle, pushing it down, because right before an ejaculation, everything becomes tight and hypertonic, getting ready for those convulsions. And so being able to feel in control of your body and being able to know that you can relax your pelvic floor is a major part of the solution here. I am not going to recommend numbing creams. This will deaden the pleasure, which is the whole purpose. It can also cause other problems. It doesn't solve the problem. There can be contact issues with your partner now. Are they numbing themselves? You know, it's messy, and it's a Band-Aid. I don't suggest it. I don't think it's even a good Band-Aid. And we do not want to encourage dissociation or distraction. Some people would say practice baseball skills or think about your third grade teacher. Those kinds of things are taking you out of the moment, which is actually not helpful. We're wanting to think about pleasure and relaxation, staying in the moment, staying with your partner, and being mindful. We don't want to encourage disassociation or distraction. Maybe suggestions. For about 10%, anxiety medications help slow this down because a panic attack looks a lot like an orgasm. Biologically, all the same things are happening. Your blood pressure is increasing, your pulse is quickening, your eyes are dilating, your breathing is increasing, and those anxiety meds are there to tamp that down a bit. And so for about 10% of people, that can help. I think it's probably helpful to have one that's not a daily, because then you're dealing with all those side effects all of the time rather than just getting the benefit at the time you need it. A testicular restraint can help, one that's a device that's cupping, that it can slow down the response. There is some indication that a latex penis ring can help, but the research is thinking this is maybe more of a placebo effect. So now let's talk a little bit about erectile dysfunction, which is the other side of the spectrum of the same experience. This is, affects about 52% of men experience some form of ED, erectile dysfunction. And that a total of ED increases from about 5 to 15% between ages of 40 and 70. So the older you get, the more likely it is that you'll experience this. Though the risk of ED increases with age, it's still possible for young men to experience ED. Let's look at what's required to have a diagnosis. Let's go back, sorry. In almost all, it needs to be happening not sometimes, right? This needs to be happening about 75 to 100% of the time to acquire this diagnosis. It needs to be marked by having difficulty of obtaining an erection during sexual activity, marked difficulty in maintaining the erection until the completion of sexual activity or an orgasm, basically, and marked decrease in erectile rigidity. These symptoms need to last for about more than 6 months and need to be causing distress to the individual. And we need to make sure that it's not better explained by a mental disorder, a medical condition, the impact of a drug or medication, or a severe relationship distress. I'm going to want to know if this is lifelong or acquired, and if it's generalized or situational. Lifelong erectile disorder is associated with psychological factors, whereas acquired erectile disorder is often more related to biological factors. Distress associated with erectile disorder is lower among older men than younger men. They begin to adapt, become more flexible. They redefine success and understand that their function changes over time. One thing that I often ask for both of these, for both premature ejaculation and erectile dysfunction, when trying to figure out if the cause is biological or if the cause is psychological or if the cause is sociological, is do you experience this when you're alone or only with your partner? And that helps us know a true biological factor will happen anytime, any context, and any situation. Okay, that helps me know we need to look heavier at the biological. But if it happens most often with a partner, but not when alone, I'm going to pretty much think, okay, this is psychological or sociological. So that's a good question to ask yourself. It's a good idea to visit your urologist or primary care physician, do some hormonal testing, and maybe work with a pelvic floor physical therapist, because an erection is not only about the blood flow in the penis, it must be supported by the whole undercarriage. And if that PC muscle is really weak, the hypertonic and too tight is associated with premature ejaculation, but too weak is more associated with erectile dysfunction, especially a rigidity. That is when pelvic floor exercises and Kegels and things like that, you strengthen those muscles, will also help increase rigidity and prevent erectile dysfunction. The pelvic floor muscles matter just as much as the blood flow. They help. Some biological treatments. First, we're going to want to know why it's happening. If it's about low blood pressure, we treat the low blood pressure. If it's due to diabetes, we treat the diabetes. If it's a prostate issue, we treat the prostate. Sleep disorders. You have no idea how much ED is caused from sleep apnea that's undiagnosed and untreated. Smoking, obesity, SSRIs, these are all issues that once treated and under control, the erectile function should come back. And also while treating them, or if they're chronic problems, an oral medication like Viagra and Cialis can be helpful. Now, these medications are PDE5 inhibitors, meaning they only impact your vasodilators and your blood flow. Viagra and Cialis do not make you think anything new. They don't make you horny. They don't make you want something. They don't increase desire. They just open up all of your blood vessels in your entire body so that if you become aroused, if you have a good idea, if you have, an erotic moment, then you will have an erection. And so it's important to know if you have headaches or anything like that, it's important to talk to your doctor about that, because it opens all the blood flow, all the blood vessels in your body. And so if you're prone to headaches, many people, the major side effect is a headache afterwards. And this is why. 40 to 80% of people find this to be successful, but it must be taken correctly. Many people do not refill their Viagra or Cialis because they might not find it useful. Maybe they were hoping for it to create desire where it doesn't. Perhaps they took it and then ate a meal and it didn't work because it metabolizes with food. There's a lot of things that you need to know about the medication to help it work. There are also vacuum diseases, injections, and prosthesis that you would move through in progression of treatment if it's a biological source. Psychological factors that can influence erectile dysfunction is chronic depression, especially those who suffer from bipolar disorder, OCD, and there's many branches of OCD. One particular is scrupulosity, which has to do with an obsession about if many people with religious backgrounds can become compulsive and obsessed with ideas about purity and things like that, that then can create erectile dysfunction. So OCD has so many branches. I guess I'm trying to clear that up about how broad it is of an experience. There's also a branch of OCD that's obsessed with worrying about sexual functioning. Yeah. Some phobias, anxiety, sexual shame. These are all psychological factors that can influence erectile dysfunction. And same as the biological things, we just try to treat the source. We try to treat the depression, we treat the anxiety or the OCD or the phobia or the shame, and hope that when those psychological concerns are resolved, then so is the erectile dysfunctioning. What about social factors? These are things like unrealistic expectations, self-pressure, negative self-image, having a critical partner, absorbing sexual shame. And so some social treatments are to work on your concept of self, your identity, to work on some cooperation as a couple, and increase the intimacy and trust and collaboration and creativity. I think it's really important for a couple to have a us against it mentality instead of it's my sexuality and yours is becoming a problem for mine. To have this us against it mentality, that we externalize the problem, where it's us trying to find a solution to the ED, or it's us trying to find a solution to the PE. And having an idea of a good enough sex model. Those are rooted in realistic expectations. Some people are moving away from the medical model and instead of seeing this as a dysfunction, looking at it as a disappointment, which I think can be really fantastic mental shift. I'm going to read this to you from something I found from Chris Donahue, is a penis is not a dildo and should not be expected to act like one. Getting and remaining erect on demand as desired for as long as needed is unrealistic. Regardless of how attracted one is to their partner, a penis will always have a diverse and variable functioning. Most people have performance-based sex and not pleasure-based sex. Performance-based sex means sex that isn't centered in what feels good or seeking pleasure or fun or being in your body in the moment. Performance-based sex is rooted in anxiety about your worth as a partner, your value as a lover, and the competence of your body. It's using sex as a tool to make you feel validated and attractive. I think that's a fascinating reframe. You might spend some time on that quote and ask yourself if it resonates or not. Pleasure, not performance, is the goal. Pleasure-based sex means focusing on what feels good, using tongues, toys, fingers, and erections if and when you have them for as long as they are maintained. Pleasure-based sex, one of the main reasons for having sex, means allowing your body to naturally do what it does and not forcing yourself to get or stay erect because of expectations, shame, or anxiety. Sex is not penetration. Sex is fun. It's pleasure, it's connection, intimacy, and growth, regardless of how it happens. When all partners when all partners that you desire have an erection but don't have one, it says that, it has something to say about their sexual maturity and their sexual health. Here are some at-home resources that I often recommend to my clients. This is going to have the medically accurate education about premature ejaculation and erectile dysfunction. It's going to have a lot of suggestions, both biological, psychological, and sociological. And I love both of these resources have exercises that you can do at home, either by yourself or with your partner. And really focuses on collaboration as a couple to make sex based in pleasure, not in performance. So where can you find me? If you enjoyed my style, or you enjoyed my content, or you enjoyed the education, you can connect with me a lot of different places. You can learn more about me on my website at www.camihurst.com. You can email me at cami@camihurst.com if you'd like information about working together, about some of the courses that I offer. You can also access me for free anytime at Sex Therapy 101. And you can also connect with me on Facebook and Instagram if you search for Dr. Cami Hurst. Thank you so much for spending this time with me today as we talk about what is sexual health, how do male bodies function, how can I resolve some concerns around ED and PE, and I hope that you and your partner found this useful and something that you can integrate into your sex life to make it more pleasurable. Have a good day. Bye-bye.